The statistics for hospital infections are staggering. 1 in 20 patients will contract a serious hospital-acquired infection. Each year, an estimated 500,000 patients in the United States will develop a surgical site infection. Along with the dangerous health risks to patients, the cost of these insidious infections is huge, about $45 billion a year. In addition, studies show that about 2,700 surgeries are performed each year on the wrong body part or patient, about 7 per day. And other adverse events, such as retained items left in patients, have been occurring at a fairly steady rate. With these daunting risk factors, North Shore LIJ Health System, one of the largest and most progressive hospital systems in the country, partnered with Arrowsight, the leading developer of remote video auditing technology, to first tackle hospital-acquired infections and later improve safety and efficiencies in the surgery department.
A hospital-acquired infection, also called a nosocomial infection, is any infection that develops in a patient who's been in the hospital for at least 48 hours and was not incubating or present when they came into the hospital. Hand washing has been shown to be the backbone of infection control for the last 150 years. Compliance with hand washing has been less than ideal in every study that's ever been done.
That is, until now. North Shore LIJ Health System conducted a 2.5-year study after installing Arrowsight's RVA technology and reported a dramatic improvement in hand hygiene compliance. The study was published in 2011 in prestigious medical journals. Arrowsight CEO and founder Adam Aronson notes some surprising results that were revealed by the RVA system at North Shore LIJ.
Hand hygiene rates that they thought were at 60% using their conventional methods of assessment, which is basically a clipboard and maybe sort of a secret nurse walking around and taking random assessments. They thought the rates were at 60%. And when we put the video cameras in and did many months of observation without giving any feedback, it turns out the rates were actually below 10%. And so within about 4 weeks of beginning to give feedback, which is done through electronic digital boards right on the walls of the intensive care unit, once all the workers and the managers could see what their real-time hand washing rates were, within 4 weeks their rates went up in over 85%. So it was a really big breakthrough.
With the passage of the Affordable Care Act, known as Obamacare, hospitals are even more motivated to find ways to improve quality health outcomes while maintaining revenues. Surgery, in particular, is a major source of hospital income, accounting for 60 to 70% of revenues. A new pilot program was designed and put in place in collaboration with North Shore's anesthesiology provider, North American Partners in Anesthesia, or NAPA. Arrowsight cameras and RVA technology were installed in March 2013 in the operating rooms at Forest Hills Hospital in Queens, New York, which is part of the North Shore LIJ system. The key OR safety measures assessed in real time by RVA monitoring include timeout, sign-out, and terminal cleaning compliance. RVA is also being used to decrease operating room turnover times.
The first and foremost thing that the healthcare system has had us focus on is timeout compliance.
By doing something as simple as getting everyone to communicate effectively through a scripted checklist to make sure that you cover all the important basic safety steps that a team may think is important in their center, that you're more likely to actually avoid missing a step, and that will improve patient outcome. And so we deployed the checklist to help improve our patients' morbidity and mortality outcomes, to make them safer.
Just as a pilot's getting ready to take off, they do a lot of checks on their plane. We do the same type of thing in the OR. That's important that we know that we have the right patient, we have instrumentation correct, the right site on the patient. So we've always done that, and the importance here was to make sure that our compliance is good. And by having the video feedback, we're really able to bring our compliance up very close to 100%.
Are we ready for timeout?
Yes, we are, doctor.
Please introduce yourselves and your roles, please.
Dr. Conti, the surgeon.
Denise, the circulator. Maria Shaw, PA. Factor.
John I. Mateo, anesthesia. We're going to identify the patient with Dr. Conti.
This is Michelle Romero, medical record 345678.
Arrowsight's remote monitoring provides data on surgical timeout compliance.
The things that we're monitoring for are very important, because if they take too short of a time, that probably means they didn't get through the whole checklist. And if they're distracted, they're obviously not paying attention, and the risk for some kind of an adverse event could be higher.
Patient privacy is also an important factor that the pilot program has addressed.
HIPAA laws are very strict, and even if you get consent, there's a tremendous amount of responsibility that we take and that the hospital takes in treating that information very, very confidentially and very carefully. The methodology that we approached this with was basically to lower the resolution of the cameras so as not to be able to distinguish anybody's identity or make out any type of body part, but at the same time have it be a resolution level that was high enough so that we could see the types of things that we're being asked to monitor for.
From a quality point of view, being able to see this done 100% of the time to make sure that we're doing the right thing for the right patient every single day in every single case is of paramount importance for all of us at the health system, and as well as for all hospitals in the nation, I believe.
While timeout takes place prior to surgery, sign-out follows immediately after to ensure that all items like gauze and medical instruments that were used during an operation are accounted for.
So during the sign-out, you're going to ensure that all accounts are correct. So that's how you engage the physician as well. We're counting, we're saying everything is here, everything is correct. We have back all our sponges, all our needles, all our sharps, all our instruments. We have back everything that was on this patient we removed, we have it. That's the most important piece.
The RVA monitoring system also confirms whether operating rooms have been cleaned properly at the end of the day and in between each case.
From an infection control point of view, which is also patient safety, we're watching how we clean the rooms in between cases. Are we cleaning them correctly? Are we spending enough time in there? Are we pulling out everything that needs to be pulled out and really wiping it down? From an efficiency point of view, which is also important, and a physician satisfaction point of view, we're seeing how we turn over the rooms. How long does it take to get the equipment in after the room's been cleaned? How long does it take to get the patient in after the room's been cleaned? And these are important in efficiency and in controlling our own costs. And in the world today, with healthcare reform, we have to find every way that we can become more efficient.
We should care about whether we're spending a half hour longer than we really need to take care of that patient safely. What wasted time can we somehow, remove? Those dollars that are saved through improvements in OR efficiency turn out to be dollars we can use to reinvest in the system to protect patients in other ways.
Arrowsight monitors the 8 ORs at Forest Hills with video reviewed once every minute. The results are very promising. Early indications show that OR turnover times can be potentially decreased by 25 minutes or more per case. That translates into increased revenues, especially when 1 hour in the OR is valued at about $2,000. With each of the 8 operating rooms able to add 1 more hour of surgery per day, that can mean $16,000 per day in additional revenue.
The feedback from the system has really been helpful, definitely for the nurses at the front desk so they know what the status of the room is. When the room is ready to be cleaned, so they send the cleaning team in. When the room is cleaned, so that the next nursing team can come and set up, and then we know to bring the patient in.
The surgical staff has also come to rely on the technology's digital capabilities, including boards showing data in real time. Surgeons and physician assistants also receive text alerts telling them when their rooms are ready for the next case.
Our initial reason for using the remote video auditing was primarily as a safety tool. We wanted to be able to give people feedback in ways that would improve patient outcome. But remote video auditing is capable of doing so much more. It allows us to objectively measure things that for years we thought we were objectively measuring, but there was always some bias. Throughput and efficiency in the operating room is mandatory today. Society is asking us to provide high-quality care at a lower cost. We can't afford high-quality care at an escalating cost anymore. We've already reached a point where society is saying it's enough. And so the real challenge for all healthcare systems is to figure out a way to improve quality with less.
We continue to look to see where else we could use remote video auditing. And a particular area is assessing compliance with personal protective equipment, usually referred to as PPEs within a hospital. And a PPE is the gloves, it's the gown, it's a respirator, it's a mask, it's any type of device that is used by an employee to serve as a barrier between themselves and an infectious agent.
There are many different things going on for us in the healthcare industry. We've talked about the infection control work evolving into the PPE compliance. We've talked about how the operating room is now a very big opportunity for patient safety and room turnover improvements. And all of this is being fueled by a recent editorial in the medical journal JAMA, which essentially promoted the concept of video recording and video monitoring as a way to provide a safer and more efficient healthcare system. So we really do feel strongly that this suite of services and many other areas within healthcare over the next 5 or 10 years could really become a standard of care.